presentation on cutaneous drug reaction. Okay, so as for introduction, as we know, there are certain types of drugs that people might be allergic of, and that is why it is important for us to ask about the drug allergy during HPI. During history taking, and these drugs can cause adverse effect reaction, which can further be divided into two types, which is type A and type B. Type A being pharmacotoxicological and type B being hypersensitivity. Most of the drugs would manifest with type B reaction or hypersensitivity. And these type B drug reactions are reproducible with repeat drug exposure and occur at drug dosage tolerated by normal patients. So these reactions are immunological, and these drugs acts as hapten or and binds to a protein where the structure formed is recognized as non-self. So this triggers the immunological reaction, and it can further be classified into immediate reaction or immune complex dependent reaction and delayed hypersensitivity reaction. So in my next slide, okay, so this I've attached the type of hypersensitivity reactions, which are immediate, antibody-mediated, immune complex, and delayed, with what are the common clinical phenotypes that patients are being presented with. For example, yeah, when they have immediate reaction, they usually present with urticarial or angioedema. And if they have antibody-mediated reaction, they would come with vasculitis and drug-induced thrombocytopenia and hemolytic anemia. And if they were to have immune complex reaction, they would have serum sickness reaction, like, and if there's delayed type, there are like Stevens-Johnson syndrome, anti-contact dermatitis, and so on, which will be further discussed in our presentation. So this would be our contents of today's presentation. So I would be presenting on urticaria, vasculitis, up to bolus drug eruption. Sorry. So okay, for urticaria, the clinical features are usually they will be presented as raised, smooth, erythematous, and itchy, and it comes in various size. It can usually be seen at skin sites, and it is associated with angioedema, which are subcutaneous edema affecting the lips, periorbital skins, or tongue, like the picture shown beside that. And they may also involve respiratory and GI mucous membranes. So these urticaria are usually um, presented within minutes of exposure, and they rarely last for more than 24 hours. And they do not leave any scars, so it fades to give normal skin. So the common drugs that may cause these are penicillins, captopril, cephalosporins, thiazides, phenytoins, NSAIDs, aspirin, quinines, and ACE inhibitor. Next would be vasculitis. So these are palpable purpuras that appear to be like small vessels, cutaneous vasculitis. And these may also evolve into hemorrhagic blisters or purpuric, known as purpuric plaques. And their locations are usually at the lower extremities.
Actually, they're not all palpable. If they are, obviously if they're deeper, they're palpable. Okay.
Okay, doctor, thank you. So I would correct my slides later. So some of it that are deeper are palpable, like what doctor said. And as for locations, they're limited to lower extremities or other dependent areas. These vasculitis often manifest within 1 to 3 weeks after starting the drugs, and it usually takes a longer interval. And common causes are antibiotics like penicillin, allopurinol, phenytoin, thiazides, tyrosils, and NSAIDs. Next, discuss about maculopapular eruption or morbilliform. So these are erythematous macules or papules of 2 to 10 millimeter in diameter, And the rashes are usually itchy, and it is caused by delayed type hypersensitivity reaction. The locations it usually starts at the trunk and spreads to the arms, legs, and maybe confluent into the large become confluent into large pellets. And the distribution is bilateral and or symmetrical. For onset, it usually develops within 1 week, and it lasts for less than 2 weeks. And the common causes are antibiotics, allopurinol, barbiturates, captopril, and thiazides. Next will be erythema multiforme. So these are skin and mucosal membrane manifested by papular villus or necrotic lesions. And these lesions have dusky or blisters in the center, like you can see in the picture down here. And causes there are several causes, and it is acute and self-limiting. So you can usually see this at the sides of knee, elbow, palm, or also favors the extremities. The common causes are anticonvulsants, sulfonamides, NSAIDs, and other antibiotics. And these usually appear within 48 to 72 hours to the drug exposure and persist at the same time. It also at the same site, and it lasts for about 7 days, and it takes about 4 weeks to resolve.
Just want to mention that infection is a common cause of erythema multiforme, unlike STS and TN. Okay, erythema multiforme was believed to be um, a spectrum of part of STS and TN, but not anymore. I think it is classified as a different entity now. So, but as it is usually caused by infection rather than drugs. Drugs can also cause it, but mostly infections. Okay.
Thank you, doctor. Uh, Next, I'll be talking about bolus drug eruption. So this is actually a very wide topic, as it comes with the sub reactions that will be discussed by Isha later. So bolus drug eruptions can be localized or mild reaction with blisters in limited area, or it can be widespread or severe reaction with extensive skin blisters or skin loss. So if it was localized and mild reaction, it usually manifests with fixed drug eruption, drug-induced pseudoporphyria, and also drug-induced phototoxicity, CCT. Sorry. And then for the widespread or severe reaction, it manifests as Stevens-Johnson syndrome, drug reaction with eosinophilia and systemic symptoms, and toxic epidermal necrosis, also known as DEN. So these further drug reactions would be discussed by Isha. So if there's no question, I would like to pass my presentation to Isha. So Isha, you can take over. Sorry, Dr. Isha has problem joining the meeting. That's why it's taking longer. Excuses, Doctor.
Sorry, come again. Can you repeat that?
Isha, are you here? No, Doctor. I wanted to say that she had problem joining the meeting. So yeah.
Another alternative is for somebody else to share the screen and she can present and
Okay.
give instructions to change slides.
Okay. Okay, doctor. Give us a minute, doctor.
Morning, Assalamualaikum. Sorry, doctor. I was having problem with my internet connection just now. Can you give me a few moments to
Okay, I'll give you 2 minutes, 3 minutes then.
Okay, thank you. Um, can everyone see my slide at this moment? I cannot see the emoji. So
Yes.
yeah, thank you. Thank you so much. So I'm so sorry for the slight delay. And apologize in advance that my slide is very, very brief because I could not find any good image to share. Okay, so considering to what Yogesh had presented just now about the cutaneous drug reaction, I will now be um I will now continue with the presentation on the other types of drug reaction that can happen when we are exposed to drug. Okay, so one of it is the fixed drug reaction. So the fixed drug reaction can be clinically defined by the unilateral recurrence at the same site with re-exposure to drugs, meaning that we can have this drug reaction when we are exposed to the similar drugs and it occurs at the same site on the skin. And this FDE, fixed drug eruption, is the second most common cutaneous reaction towards oral medication. We will expect that topical drugs can be the cause of this cutaneous drug reaction, but no, it is the oral medication itself. Um, and however, these topical drugs is rarely seen with these types of cutaneous drug reaction. And the examples of drugs involved for this fixed drug reaction, one of it that we commonly use is the non-steroidal anti-inflammatory drugs, NSAIDs. Second is the tetracycline. Third is the trimethoprim sulfamethoxazole. And another is sedative and also anticonvulsant can also give these types of drug reaction. And um, how do we identify this fixed drug reaction is by when patient is presented with isolated or small groups of well demarcated lesion. It can be round to oval shape and have a dusky red macules with patches. And the size can be as small as coins, and it can be also the biggest that can go is up to 1 to 2% of body surface area. And this FDE can also may gradually develop into bullae. So the predilection over thin areas, meaning that there are certain areas that this fixed direction can be erupted on the skin, is at our thin area on the lips, on our genitals, and also at our perianal regions. It can also happen on our trunks, abdomens, our hands, but they mostly go for the thin area first because that is where we are prone to have skin eruption, right? And it can also happen in mucosa area. However, this one, it does not involve with other types of area. It only happens in solitary lesions. And if we look at histologically, um, this lesion involve at the dermal epidermal junction, where we can see there is abundance of neutrophils and eosinophils microscopically. The second type of cutaneous drug reaction that I'm going to present is the acute generalized exanthematous pustulosis. So this one is characterized by an exanthem with numerous small and non-follicular sterile pustules around our neck, axilla, and also groin, with sudden onset, with gradual onset. Sorry, and it usually starts a few days of drug exposure, and it goes by with peeling as skin resolve. And localization forms can occur, and florid cases can resemble pustular psoriasis. And what are the drugs that can give this acute generalized xanthematous pustulosis is the antibiotics. For example, are the aminopenicillins, macrolides, can also be topical such as antifungals, um, calcium channel blocker, diltiazem, and also antimalarials. The third type of drug reaction that I will be presenting is about the DRESS, drug reaction with eosinophilia and systematic symptoms. So this one will start 2 to 6 weeks after the initial exposure to drugs, and it can further be characterized by the widespread erythema, also presented with facial edema, fever, and also lymphadenopathy with organomegaly at the liver and spleen. And blood eosinophilia can also be seen with presence of elevated hepatic transferase. And what are the drugs that can cause this type of reaction is the aromatic anticonvulsant, for example, as carbamazepine, phenytoin, lamotrigine, and also phenobarbital. Allopurinol can also cause this DRESS, and also the same goes with sulfonamides. The last one, which is we can encounter, this is Stevens-Johnson syndrome and toxic epidermal necrolysis is the same spectrum of disease with the erythema multiforme presented by Yogesh just now. So um, um, okay, so Stevens-Johnson syndrome and toxic epidermal necrolysis is an acute but life-threatening mucocutaneous reaction. And how it characterized is that if our body surface area involve about 10% of the lesion, if the lesion covers about 10% of the body surface area, we define it as Stevens-Johnson syndrome. But if it covers more than 30% of our body surface area, we characterize it as toxic epidermal necrolysis. In between the 10 and 30 is we classify as SDS and TEN. It is overlap. And this toxic epidermal necrolysis and SDS is more frequently happen in females with and it can also be induced without drug reaction. For example, it can be induced by the measles, mumps, rubella vaccination, and also microbial pathogens such as the mycoplasma pneumonia infection. This can also induce SDS and also TEN and necrolysis. Um, and the high risk medication that can trigger this SDS and TEN
For
is
that, I just want to mention that
Yes,
as uh, SJS and TN, majority of them are caused by drugs. But erythema multiforme is mostly caused by infection. Okay, so if you see somebody with SJS or TN, you have to look for a drug cause. Okay, um, is when they have not taken any drug at all, then you can think about infection. But always look for drug causes. Sometimes the patient does not remember taking certain drugs, or it could be a herbal supplement or any supplement at all. That could be the cause of SJS or TN, but a drug history is really important. Okay, sometimes you have to go through the notes, ask the patient again and again, ask for collateral history. So it's only after you have done a detailed drug history that you can exclude drug as a cause and look for infection. Okay.
Okay, thank you so much, Doctor, for the clarification. And to further assess the severity and prognosis of Stevens-Johnson syndrome and also toxic epidermal necrolysis, we can use the scoring system called SCORTEN, SCORTEN. So this help to assess the severity and also the prognosis, and help in further for us to give further management to the patient. Um, and oh yeah, the drugs that can triggers this Stevens-Johnson syndrome and also toxic epidermal necrolysis lesion is one of it is the antimicrobial sulfonamides, sulfasalazine, also allopurinol, nevirapine, lamotrigine, carbamazepine, phenytoin, phenobarbital, and also NSAIDs. This can also trigger this kind of lesion. And oh yeah, antibiotics such as the aminopenicillin just now and cephalosporins can also trigger this kind of cutaneous drug reaction. E- yeah, I think that's all for my presentation. I'm sorry I could not include the pictures here. There was some problem with my PowerPoint just now. Okay, that's all for me.
There's a couple of points. Fixed drug eruption is also it's also called fixed drug eruption. Then I think don't see any photos in this presentation.
Yeah, Doctor, because my PowerPoint does not sync with my laptop. I'm not sure why.
Okay, but
But
it's important that you
share.
look at the examples of photos for each condition, and then yeah,
Yeah,
so that recognize the drug reaction when you see it. It takes training, actually, years and years of training, but SJS and TN, hopefully all of you can recognize it. I think you mentioned the Scotten, so that's fixed drug eruption. Okay. You mentioned about Scotten, which is a scoring basically to predict the prognosis and mortality rate in these patients. I think in practical point of view, usually we use that as a justification to try and get an ICU bed. Usually these patients are ideally managed in ICU or burns unit. I think we haven't talked much about the management, but they are usually patients that are managed in an ICU or burns unit by a multidisciplinary team, including anesthesia, pain management team, dermatologist, and they involve mucosa. I remember that. So the mucosa involvement might involve management from the ophthalmology, ENT, dental, respiratory, if it involves the respiratory tract, uro gynecology team, depending on the side of involvement. Okay. it's important that you monitor for infection, and also look at the monitor the fluid and electrolyte balance as well. And don't forget nutrition. Okay, nutrition is an important issue in these patients. Okay. I think that's really, in a nutshell, is actually a topic that can be the whole day or the whole week, even in a conference. But I think you have to go back and look at the photos, because these might come out in the exam. Okay, any questions?
I think no.
Okay, the mucosal involvement, can I have a look at the slides again on the
Oh,
SGS and TN?
okay, yeah. Wait for a moment, doctor. Sorry.
Doctor and
Yeah.
Sha, maybe I think I want to ask something
Yeah,
about
sure.
the necrosis mentioned before. So like does necrosis look like blackish kind of a rash?
Blackish, is that the question?
Yeah.
Okay, so um it might not be blackish initially. Okay, they might present with the I don't think was mentioned, but a common morbilliform drug eruption, which looks like basically like measles. Okay, patchy, or papular, macular, or even plaques of erythematous eruption. It can be very mild at the beginning, but it can progress, okay, with a more widespread eruption. They then develop tenderness and blister formation. Okay, the tenderness and the blister formation and the mucosal involvement are the characteristics, the features that you should look for to suspect toxic epidermal necrolysis. And like you mentioned, when it becomes necrotic, it can be blackish, but really, sometimes it's not really blackish, it's actually grayish or dusky kind of color. Not really black per se. Yeah. But usually they're tender, and is again, this is not mentioned. I think they developed this sign called Nikoski sign, which is blistering or erosion occurring when you apply gentle rubbing on the skin. So these are the important features of SGS or T. So yeah, that's the answer to your
Sorry.
question.
Yes, doctor. So for the Nikoski, it's like if you rub and it goes like
From
um,
blisters or erosion with gentle pressure or rubbing. That's Nikoski sign positive.
does it like it slip away to the based on like
It's
what I read
so
the Nikoski.
on normal skin, if you rub your normal skin, they don't form blister easily, right? Okay, unless it's really edematous or already inflamed or irritated. But that's for normal skin. When you rub it, it doesn't form blister. But if you rub a skin that is involved, an area of redness, for example, or in TN, usually these are areas of either redness or dusky, or that has a dusky color or grayish color, tender. So when you apply pressure, they will form blister or erosion very easily. Yeah.
All right. Okay.
Yeah, you can see that.
See
Yeah,
that.
in the sign. So these are, you can see, well, in the top right photo, the whole area is just diffuse erythema, and on top of there's diffuse erythema and dusky grayish kind of color. But when you apply pressure, like rubbing, like the arrow, in the arrow area, it forms blister. Okay, that's quite a good photo. That's a clear photo actually. sometimes you can just see small erosion. So that's why they need like gentle handling, sterile, as sterile as possible. Okay. In the center, I think in the center, top center photo, top photo in the middle. That's it. Again, it shows Nikoski sign when rubbing the skin. I mean, it doesn't have to be like a, uh, um, you know, uh, pressure, too much pressure. It's actually gentle rubbing, usually can cause erosion in these areas, especially when it's already necrotic. Okay, so there are different photos that you can see, but you just compare with your normal skin. When you rub it, you don't form blisters, right, on your skin, but this is different for SGS and TN. Saying that, sometimes at the beginning when they haven't it's not they haven't developed that full thickness necrosis, it hasn't it's not that severe yet, they don't have Nikolsky sign yet, doesn't mean that they don't have SDS and TN. Yeah. Okay.
Okay,
Do
doctor.
you understand that?
Yes, doctor.
Yeah, Nikolsky sign is important, it's a feature, but at the beginning, when you don't have Nikolsky sign, it doesn't mean that you can rule out SDS or TN, because some areas might have developed that full thickness necrosis yet. Yeah. Okay. I think like I said, it's very important for you to have a look at the photos. The timeline is a bit different from EJAB, dry syndrome, SDSNT, and have a look at those. And yeah, I think those are the important things. Common medications, timeline, features, the systemic involvement. Some of them has less severe systemic involvement, or even maybe not that common. Some of them have a lot of systemic complications, SGS and TN is the most severe, and it doesn't involve the skin only, it can affect other organs as well. Okay. I think it's very important for you to look at mobiliform drug eruption that I mentioned just now, because it's very common. There are other drug reactions that are not really hypersensitivity reactions. Some drugs can cause, for example, hyperpigmentation, discoloration of the skin. You might look into that. Do you know any examples of drugs that can cause hyperpigmentation of the skin?
The minocycline
Yeah, somebody. Yeah, did you Google that? Yeah.
in a book.
Yeah. So yeah, one example is minocycline. So it's not just hypersensitive reactions. You should have actually looked into the different skin manifestations from other from drugs as well. Okay. Minocycline is one of them. That's why in the past we used to prescribe minocycline a lot for acne, but not anymore, because it has a lot of side effects. Yeah. Any other questions? There are other more rare conditions like drug-induced lupus. There are all sorts of drug reactions. But these are the most important thing. But you should go back and read about those. Okay. All right. Any other questions? Make sure somebody gets a attendance, yeah. Okay.
Okay, doctor.
Mm-hmm. Have you seen a drug reaction in the wards?
Yes, doctor, in pits.
Oh, okay. What kind of drug reaction did they get?
SJS.
Oh, okay. When was that?
When was that?
Yeah.
Uh,
Is it now?
last
Do they have a patient now?
no, last month or last 2 months.
It was actually at HRP's at ward, doctor.
Oh,
Yes.
HLP side. Okay, yeah. Because if it's in if it's in HUSM, I would have known about it. Hopefully.
Mhm.
Yeah. So was it severe? Was the patient in ICU?
No, but she has
Mm,
like mucosal eruptions. Like she has difficulty feeding.
absolutely. Yeah. Oh, they're in a lot of pain. I've mentioned that they need pain management team. Yeah.
Yeah.
But they're in a lot of pain. I've recently had, I think the last 3 patients that I had are very severe. I got 2 of them admitted to ICU, but of course the beds are limited. So one of them were already in ICU. One got admitted for about a couple of days, and then was discharged. Was transferred to a general ward as he was stable. But yeah, all of them had bad mucus involvement. One of them actually, a patient I saw in emergency department after being referred to me, and he didn't even want to talk. So yeah, pain management is very important. Sometimes they need an NG tube inserted for feeding, because obviously when your mouth, the whole mouth and mucous lips are ulcerated and eroded, you can't really eat properly. So sometimes they need NG tube, but fortunately that patient actually improved a lot in the next couple of days. So but he refused NG tube anyway, but he did improve. So he was able to eat and drink not long after he was admitted. So that's a good thing, but it's not always the case. Okay. Okay, we have quite a few cases actually. I mean, it's supposed to be SDNT and it's supposed to be rare, but I've seen on average about 1 case per month, which is quite common, compared to the incidents reported in the journals. Yeah, I've seen AJAP as well, acute generalized exanthematous pustulosis. I think that was caused by antibiotics. Again, it was involving I think it was involving the whole body. But okay, fortunately, she actually improved a lot within a week as well. Dry syndrome, yeah, I've seen one, I think so far. So it's not that uncommon. So you see it from time to time. But I think I just want to stress on the importance of monitoring for these drug reactions. They might actually present initially with a just patchy eruption, just unremarkable erythematous patchy eruption at the beginning. When I say patchy, they're not that much, they're not widespread at the beginning, but they later progress and form tenderness and blisters, this dusky kind of color. Um, I've seen a few of them developing this, okay? So it's not always tender from the very beginning. They might progress from a mobile, from a different type of drug eruption, and they might progress into SDS and TN. Okay, and of course, as I've mentioned, they can have systemic involvement, so you have to monitor the bloods as well for, they can get, liver hepatic involvement. And when they have widespread eruption, um, especially with blistering, you have to look at the fluid balance and the electrolyte balance too. They can get hypothermia if it's really severe, they lose heat from the body. Yeah. Okay. Fluid. And I mentioned nutrition is also an issue. Okay. Because of the feeding and also the fluid loss and everything. Okay. All right. Any other questions? Hello?
Doctor,
Mm-hmm.
is there like a significance for us to like to know how do we classify SJS and TN? I mean, how do we just classify them based on observation, like according to the percentage
Yeah, I think it
of
was already mentioned. There wasn't a diagram on it, but the presenter has already explained that it is according to the body percentage of body surface area. So 10% or less is SGS, between 10 to 30% is SGS-TN, and more than 30% is TN. Obviously, the higher the percentage of body surface area affected, the higher the mortality. We have the score 10. If you want to classify according to the prognosis, that's you have score 10 or ABCD score. So, but usually the most commonly used is score 10. I don't think. I mean, those are the common classifications that we use. Anyway, the board it's either SDS, SDSTN overlap, or TN, and the score 10 for prognosis. But is there any like other classification that you're referring to?
no, I'm just asking like so based on what I understand, maybe we just count the percentage based on the palm,
Yeah,
right, of the
that's the
patient.
most, yeah, because obviously when they have more blistering areas, eroded areas, they get more complications. So that's why it's usually according to the percentage of body surface area affected and the mortality rate, predicted mortality rate based on the score 10. I think, yeah, because the involvement is really common and usually severe, but not for all. Like is again, it comes in a clinical spectrum. They might initially present with a mild eruption, but later on progress into SGS and TN. Okay, so that's why for score 10 usually you um calculate the score at the beginning on the presentation, and then you repeat it again 2 or 3 days after. Okay, because obviously this can progress. They might have like 10%, because 10% percentage body surface area affected at the beginning, but it can be like 30%, 50%, or even 90% in a few days. Okay. And therefore the mortality rate predicted for that patient is different then. Okay. Any other questions? Do I have another class with you? Hello?
I think no more class.
Sorry? Your voice is a bit muffled. Hello? Hello?
Hello, doctor.
Yeah?
I think for Dermato already no more class for Dermato.
Okay. All right. Do you have any other questions?
No.
Yeah, and Doctor, I actually have one question. So,
Yeah.
about the Nikolsky sign just now, how do we differentiate it with the Staphylococcus skin infection? Because that is also a scalded skin, right?
Yeah.
Does it have any difference with
No,
um?
no, Nikolsky sign is Nikolsky sign. When you have, of course, it can be positive in an SSSS as well, but if SSSS has a different cause. It's caused by obviously staph aureus infection. And therefore history is very important. Okay, it's very drug history is very important.
All right, thank you so much.
No worries. Okay, any other questions? We still have a bit of time, but yeah, any other question from other lectures that we had?
Not yet, doctor.
Okay, all right. So you need to revise, obviously. Okay, I think if you have the slides with the photos, you should actually share it with your friends, because you can't have a dermatology lecture without photos, right? Yeah. So it should always be with photos, because that's otherwise you will not be able to recognize the condition easily. Okay. Even with photos, you need training to actually recognize. But without photos, how can you imagine? What they look like. All right. Okay.
Doctor.
Is everyone awake or not? Or are you guys still sleeping?
I
How
think
many
later
should be?
Isha will send the slides, doctor.
Sorry, come again.
I think Isha will send the
Okay.
slides she has.
Okay. Okay. How many of you should be in the class? How many of you are in the class?
43. Should be
Hmm?
43.
Yeah, but there's only 30. So I want the attendance sent to me. Okay. Uh, who's the leader?
It's me later.
It should be convenient enough for you to do to attend the classes, since it's online. It doesn't matter where you are, right? So we have 13 people not attending. This is not acceptable. Yeah.
Yeah, I will screenshot the attendance list from the website. I will send to the.
Perfect. Okay.
Okay.
Okay. Any other questions? So if there are no more questions, then we can end the session. I'm away in for a conference this week, but for those of you who have class with me, these other classes, that we can schedule them sometime next week. Yeah, is that all right?
Yeah, doctor, I would like to bring to attention that someone says that they shared one laptop, so that's why there's only one login.
Come again?
Someone stated in the chat box that they log in with one laptop and they're sharing with a few people. So maybe
Why?
that's what.
Why? Okay, unless they log in now, I mean, they're considered absent. Okay, I mean, you have phones now, right? You can access the session through phone, right? So how would I know whether you're really sharing the laptop or just dozing off, and someone else is saying that you're sharing the laptop with them? Yeah. Okay, unless you log in, it's considered absent then, yeah, because you have your phone, and I presume everybody has a laptop now. And even if you don't have your laptop with you physically, then you have your phone, I hope. So who's going to take the attendance?
Me, Doctor.
Was it Aiman, is it?
Yes, Aiman.
Okay, so you take the attendance. I don't understand why do you have to share a laptop. Well, you might share a laptop, but you still should log in, okay, for your attendance. Okay. Other than those who have logged in, I cannot say that you've attended. You don't have a proof. And there's a name with a dot only, so I don't know what that is. Okay. I don't know who's the person with a dot as the name. And even when I've mentioned this, there's only 33 people logged in. Okay. I don't lose anything. Okay. If you don't attend, you don't get the lecture. Okay. And did someone record this? You, no, it's just a question. Did someone record the lecture?
Yes, Doctor, already record.
Okay, I want you to delete the recording
Huh?
because those who did not attend, they should not get the recording. I mean, you should ask for permission before recording anyway. Okay, nobody asked for my permission. Okay,
Yeah.
who has the recording?
Right now should be in the Webex cloud lah.
Webex Cloud. And who has the Webex recording then?
The host lah.
Hmm?
The host for this meeting session.
Who's the host?
Please.
Hmm?
This one.
Hmm?
Me, Doctor.
So that I did not consent for this to be recorded,
Okay.
and those who attend the class,
Hmm?
will get the knowledge. Those who did not attend should not get the recording,
Got
or
it.
even those who attended. I mean, this is not I didn't give any consent for this to be recorded, right?
Okay, okay.
Yeah.
Okay. Boleh, Doctor.
Hmm?
Boleh, Doctor. Yep.
So can you delete it now? Stop and
Okay,
then
okay.
delete it. Okay.
Okay.
I don't want this to be a norm. I don't